Disorders of Childhood and Adolescence, a recap of Chapter 15 of the PMHMP Review and Resource Manual, 4th edition. Disorders first diagnosed in infancy, childhood, or adolescence, such as conduct disorder, oppositional defiant disorder, attention deficit hyperactivity disorder, Rett syndrome, autism, eating disorders, intellectual disabilities, are considered brain-based illnesses and have many similarities to disorders diagnosed more commonly in adulthood. In addition, these disorders are often missed during childhood and adolescent years and are therefore not identified until early adulthood. The disorders diagnosed during childhood or an adolescent differ in presentation based on the developmental context of the person, age of onset, and gender. Assessment, treatment, planning, and therapeutic interventions for these disorders must always occur within the context of the family and assume a multimodal, systems-oriented approach to care. In addition, assessment of children is different from assessment of adults. Prior to making a psychiatric diagnosis, all possible medical causes of the symptoms must be ruled out. Therefore, psychiatric mental health nurse practitioners must apply principles of child assessment to care and have a good understanding of normal growth and development to detect what is disordered. Effective assessment, diagnosis, and treatment is completed in the context of a family system. However, family is defined for the client. Assessment and care planning for children and adolescents requires alteration in the assessment process. Generally, takes more time. The PMHMP must develop trusting relationship with the child to put him or her at ease. Interview the child and parent separately. The child can provide information on internal symptoms, and the family or care providers can provide information on external signs. They must attend to the developmental needs and interests of the child, must attend to the cognitive and language abilities of the child. The mental status examination needs to be modified to reflect developmental and other age-related issues in children. Often requires establishment of a play environment to open communication with the child. The conclusions must consider age and developmental processes, physical appearance and dress for the weather and age group. Gait and motor skills are assessed on expected normative behaviors for the age. Parent and child interaction. Observe interaction in the waiting room. Examine the way the parent and the child talk with one another and emotional overtones. Separation and reunion. Examine how the child reacts to separation and reunion with a parent. Speech and language. Assessed on expected normative and appropriate language used for the age. Comprehension, word selection, and range of vocabulary. Rate, rhythm, latency, intonation, spontaneity. Mood and affect. Mood is the verbal admission of feelings or assessment based on themes, play, and fantasy. The affect can be a range of emotions expressed, appropriateness of the affect to the thought content. Thought process and content. Thought process, watch for looseness of associations, magical thinking, perseveration, echolalia, ability to distinguish fantasy from reality. By age 4, children have some understanding of what is real and what is made up, and watch for flight of ideas. Thought content is watch for suicidal or homicidal ideation, perceptual disturbances such as hallucinations. Social relatedness is watching for the child's response to the interviewer. Motor behavior, coordination, activity level, involuntary movements, tremors, tics, unusual asymmetries. Cognition, watch for intellectual functioning and problem-solving abilities. For memory, test recall after 5 minutes. School-aged children should be able to remember 3 objects after 5 minutes. Abstraction, assessed on expected normative behaviors for the age. Children ages 12 or younger are not expected to have abstractive thought abilities. Young children have concrete thinking. Proverb testing and similarity testing require prior exposure to the concept, word choices, and ability to think abstractly. So children ages 12 or younger are not expected to have abstractive thought abilities. Judgment and insight. the child's view of the problem, the child's understanding of what he or she can do to help the problem. Therapeutic care planning is a variety of effective treatments commonly used with children and adolescents, such as play therapy, art therapy, bibliotherapy, orative therapy such as storytelling, family narrative therapy, behavioral, interpersonal, cognitive, milieu, and pharmacotherapy. Oppositional defiant disorder. Oppositional defiant disorder is an enduring pattern of angry or irritable mood and argumentative, defiant, or vindictive behavior lasting at least 6 months with at least 4 of the associated symptoms: loses temper, touchy or easily annoyed, angry, resentful, argues with authority, actively defies or refuses to comply with rules, blames others, deliberately annoys others, spiteful or vindictive. The etiology could be temperament or parents who model extreme ways of expressing emotions, trauma, or unresolved conflicts. Prevalence and demographics of oppositional defiant disorder. ODD is more common in children of parents with a history of ODD. Conduct disorder, ADHD, antisocial personality disorder, mood disorders, or substance abuse disorder. It affects 1% to 11% of the general U.S. population, with an average of 3.3%. It's more common in males, and about 30% of children with oppositional defiant disorder develop conduct disorder. Risk factors for oppositional defiant disorder are genetic and physiological, temperamental, and environmental. Prevention and screening for children with oppositional defiant disorder. There's at-risk family education, stigma reduction, signs and symptoms of the illness, and treatment potential for control of symptoms, well-child visit, mental health screening, early recognition, intervention, and initiation of treatment. Secondary prevention is important in younger clients. Oppositional defiant disorder assessment. Assess the following: a detailed history of present illness, including time frame progression, social history, medication use, initial and periodic functional history, validate history with a family member, and assess for substance or alcohol use. Physical findings are not nonspecific. The mental status exam findings in mood, there will be lability, low frustration tolerance, angry, argue, and lose temper. The concentration is generally impaired. The thought content often blame others for their mistakes. Diagnostic and laboratory findings. There's no specific test, but complete a CPC can profile thyroid function B12 to rule out metabolic causes and drug toxicity if indicated by history. Also to consider are lead toxicity and toxicology screen to rule out a substance use disorder. Differential diagnosis for oppositional defiant disorder are ADHD, mood disorders, substance use disorders, intellectual disability, conduct disorder, and psychotic disorders. For clinical management, rule out and treat any conditions that may contribute to the current symptom manifestation. For pharmacological management, it's nonspecific. There's not a first-line treatment for oppositional defiant disorder. Target the symptoms such as mood and aggression. Non-pharmacological management is therapy is the mainstay of oppositional defiant disorder. Individual therapy or family therapy with emphasis on child management skills. Evidence-based treatment is child and parent problem-solving skills training. In the Incredible Years is a group intervention, and the parent-child interactional therapy is individual or family intervention. There's also the Adolescent Transition Program, or ATP, which is individual or family and group intervention. Moving on to conduct disorder. Conduct disorder is a repetitive and persistent pattern of behavior in which the rights of others or societal norms or rules are violated. The presence of at least 3 of the following criteria must be present in the past 12 months, with 1 in the past 6 months. Aggression toward people or animals, bullies, threatens, intimidates, and initiates fights, uses weapons to actually cause physical harm, destruction of property, engaged in fire setting or destroying property, deceit or theft, breaking into houses or buildings or cars, lying and stealing, serious violation of rules, staying out late before the age of 13 or running away from home before the age of 13. And child onset before age 10 or adolescent onset if after age 10. So it could be conduct disorder, child onset before the age 10, or you would specify that it's adolescent onset, obviously, if it's after age 10. The etiology of conduct disorder, there's no single factor accounts for presentation of the etiology is largely unknown. There's many psychosocial factors that contribute to the development. The prevalence of conduct disorder is more common in children of parents with antisocial personality disorder, alcohol dependence, mood, schizophrenia than the general population. Incidence and demographics is that it affects 2 to 10% of the general population, and the onset is earlier for boys at ages 10 to 12 than for girls. If it's diagnosed in girls, the onset tends to be at 16. And I just mentioned that. Risk factors are genetic loading, temperamental, lower than average IQ, that's for conduct disorder. Environmental, it could be family rejection and neglect, unsupervised, or physical or sexual abuse and substance use. Prevention and screening are at-risk family education, reducing the signs and symptoms of the illness, early recognition, and so on. For assessment is detailed history of the present illness, suicide, social history, medication use, and all the past history. The mental status exam findings for conduct disorder. For affect, we'll find irritability, angry, uncooperative. The mood is anger. Thought content is lack of empathy or concern for others. Concentration is distractible, and the insight is poor. Differential diagnosis for conduct disorder is ADHD, oppositional defiant, mood disorders, PTSD, substance use, and developmental disorders. For clinical management, rule out or treat any conditions that may contribute to the current symptom manifestation. Pharmacological management, there's no specific pharmacological interventions for conduct disorder. Aggression and agitation, treated with antipsychotics, mood stabilizers, SSRIs, and alpha agonists. Non-pharmacological management for conduct disorder is multimodality treatment programs that use all available family and community resources. Behavioral therapy is the mainstay, individual and family. Lifespan considerations for conduct disorder is it may be diagnosed in clients ages 18 or older if the criteria for antisocial personality disorder are not met. Attention Deficit Hyperactivity Disorder, ADHD. ADHD is a persistent pattern of inattention or hyperactivity, impulsivity, or both that interferes with functioning and development. For diagnostic criteria, there would need to be 6 or more symptoms from each category of inattention or hyperactivity, or it could be mixed. The following symptom list for inattention are fails to give attention to details, difficulty sustaining attention, does not listen when spoken to, does not follow through on instructions, disorganized, avoids or dislikes tasks that require sustained mental effort, loses things, distractful, and forgetful. Hyperactive and impulsive symptom list would be fidgets, leaves the seat, runs or climbs, unable to engage in quiet activities, always on the go, talks excessively, blurts out information, difficulty waiting turn, and interrupts others. Several symptoms were present prior to the age of 12. There are 3 subtypes. There's ADHD inattentive type, ADHD hyperactive type, and ADHD combined type. The inattentive symptoms, with the inattentive type, then it means the inattentive symptoms dominate, and there's lack of criterion symptoms for the hyperactivity. For the ADHD hyperactive type, hyperactivity symptoms dominate, and there's lack of criterion for inattention. In other words, less than 6 symptoms from the inattention. And the ADHD combined type, there's criterion symptoms are met for inattention, and also for hyperactivity. So they have 6 of each minimum. For etiology of ADHD, there's many biopsychosocial factors that contribute to the development of ADHD. Polygenic neurobiological deficits are associated with ADHD. Problems with executive functioning, abnormalities of the fronto-subcortical pathways, frontal cortex and basal ganglia, abnormalities of reticular activating system, and structural abnormalities producing neurotransmitter abnormalities, such as dopamine dysfunction and norepinephrine dysfunction. So those 2 neurotransmitters are implicated in ADHD. That's dopamine dysfunction and norepinephrine dysfunction. Incidence and demographics. 5% of children and 2.5% of adults in the United States have ADHD. Boys are more likely to be diagnosed than girls. The average age of onset of ADHD is 3 years of age, and the mean age of diagnosis is 9 years old. Approximately 60% of clients have symptoms persisting into adulthood. Inattention symptoms are more persistent than the hyperactivity and impulsivity symptoms. And I'll repeat that. Inattention symptoms are more persistent than the hyperactivity and impulsivity symptoms. Risk factors for ADHD are genetic loading, pregnancy and perinatal complications, family conflict. For environmental risk factors for ADHD are low birth weight, neglect, foster placement, alcohol exposure in utero. For temperamental risk factors, there's reduced behavioral inhibition. Prevention and screening for ADHD. At-risk family education, community education, stigma reduction, and the same thing like all the others. Early recognition, intervention, and so on. Physical exam findings for ADHD. Minor physical anomalies at higher rates in people with ADHD than in the general population are hypertelorism, which is increased distance between body parts, high arched palate, low set ears, and higher than average accidental injury rates. Mental exam status findings for ADHD. Restless, inattention, distractible speech patterns, overproductive speech patterns, affective lability, poor memory, and poor concentration. Diagnostic and laboratory findings are nonspecific. Differential diagnosis is understimulated home environment, substance use, major depressive disorder, bipolar, these are differentials for ADHD, and stereotypic movement disorder. Clinical management for ADHD. Pharmacological management, most commonly used agents are listed in the table. Right here, there's stimulants, Schedule II, and controlled substances that carry risk for abuse. Monitor for side effects and adverse effects of stimulants, such as GI effects, GI upset, cramps, anorexia, weight loss, blood pressure changes, increased pulse rate, growth, suppression is a side effect, but it's rare, headaches, dizziness, irritability, and psychosis is also possible, but it is rare. I'm not going to name all of these off, but I'll name a few of them off. They're not listed, they're not separated out by category, they're all just mixed in, so I'm just not even gonna start breaking that down right now. But there's Ritalin, methylphenidate, it's a Schedule II, and the dosage range is 5 to 40. There's Concerta, which is methylphenidate hydrochloride, and that's dosage range 18 to 72, also Schedule II. All of these are Schedule II. Let's try this one. So this one is Intuniv guanfacine, which is it's an alpha agonist. It's obviously not a controlled substance, and it is approved, FDA approved for ages 6 to 17. The Intuniv or guanfacine dosage range is 1 to 4 milligrams per day. Another alpha agonist is catapress clonidine alpha agonist. This one is not FDA approved. So Intuniv is FDA approved for ages 6 to 17, and then catapress or clonidine is an alpha agonist that is not a controlled substance and not FDA approved. There's also Wellbutrin, which we know as a DNRI, and it's also not FDA approved but often used for ADHD. And there's of course Ritalin. The most common is Ritalin methylphenidate, which we talked about. Ritalin long-acting SR, and the dosage range is 10 to 60 for that. And that's all I'm going to mention there. The side effects I already mentioned. Non-pharmacological management of ADHD are behavior therapy, patient and parent cognitive behavioral training program. That was a practice test question. So non-pharmacological management for ADHD, one of them is patient and parent cognitive behavior training program. So not just for the patient, but for the patient and parent. There's psychoeducation, treatment of learning disorders, family therapy, and education. Typical family concerns are stigma, anger, concerns over treatment options, presence of controversial information in the media, claims of dietary causes of the disorder, and belief in family ideological factors. Parents, they can also struggle with difficult emotions such as stress, self-blame, self-isolation, embarrassment, depressive reaction, and marital discord. Common comorbidities with ADHD are major depressive disorder, bipolar, anxiety, oppositional defiant, substance use, tic disorder, and learning disorders. ADHD follow-up: monitor clinical progress over time. Use standardized rating scales such as the Conners Parent and Teacher Rating Scale, which is copyrighted, and the Vanderbilt ADHD Diagnostic Parent and Teacher Rating Scale, which is in the public domain. Monitor attainment of growth and development milestones, and symptoms may persist into adulthood, so plan for long-term needs. Autism spectrum disorder description: persistent deficits in social communication and social interaction across multiple settings associated with deficits in social reciprocity, nonverbal communication, developing, maintaining, and understanding relationships. Restricted repetitive behavior, stereotyped or repetitive motor movements, insistence on sameness, and highly restricted with fixed interests and hyper or hyposensory input. Autism etiology: there's no single factor that can account for the presentation. The etiology is largely unknown. There's many biopsychosocial factors that contribute to the development. Prevalence of autism spectrum disorder: it affects 1% of the U.S. population, but the disorder is more common in boys. Imbalances of glutamate, serotonin, and GABA are thought to be implicated. So that's glutamate, serotonin, and GABA. Brain imaging studies of children with autism reveal microscopic and macroscopic abnormalities of the amygdala, hippocampus, and the cerebellum. There's decreased numbers of Purkinje cells in the cerebellum that are thought to play a role in the development. Incidence and demographics: autism spectrum disorder is more common in children with a family history of pervasive developmental disorders. The concordant rate for identical twins with autism is 60%. The incidence is 2 to 5 cases per 10,000 in the United States. The male to female ratio is 4 to 1, so 4 males to every 1 female develop autism spectrum disorder. The onset of symptoms is before age 3. About 10% of people with autism also have a genetic or chromosomal condition such as Down syndrome or Fragile X syndrome. Let me say that one more time. About 10% of people with autism also have a genetic or chromosomal condition such as Down syndrome or Fragile X syndrome. That's 10%. Risk factors are male, intellectual disability, and genetic loading. Prevention and screening for autism is at-risk family education, community stigma reduction, early recognition, and secondary prevention is important in young clients. Autism spectrum disorder assessment: assess the following: impairment with social interaction, communications, and behavior, impaired social interactions such as abnormal gaze, posture, and expression in social interactions, lack of peer relationships, emotional reciprocity, and spontaneous seeking of enjoyment, impaired communication such as a delay or lack in the development of spoken language, impaired ability to initiate and sustain conversations, repetitive and stereotyped use of language, and inability to play with others. Restricted, repetitive, and stereotyped patterns of behavior, interests, and activities, such as inflexible adherence to specific non-functional routines and repetitive stereotyped motor mannerisms, such as hand or finger flapping, rocking, swaying. Parents may report any of the following symptoms: no cooing by age 1, no single words by 16 months old, no 2-word phrases by 24 months old, loss of language skills at any time, no imaginary play, little interest in playing with other children, extremely short attention span, no response when called by name, little or no eye contact, intense tantrums, fixation on single objects, unusually strong resistance to change in routines, oversensitivity to certain sounds, textures, or smells, appetite or sleep, rest disturbance, or both, and self-injurious behavior. Physical exam findings are nonspecific. Mental status exam findings for autism spectrum disorder is little or no eye contact, flat or blunted affect, lack of emotional reciprocity, stereotyped or repetitive motor mannerisms, excessive and receptive language impairment. Screening for autism spectrum disorder are modified checklists for autism in toddlers, so that's MCHAT for toddlers, Autism Diagnostic Observation Schedule generic, that's ADOSG. So Autism Diagnostic Observation Schedule generic, that's ADOSG, and Ages and Stages Questionnaire, ASQ. For diagnostic and laboratory findings, there are no specific lab tests. Autism spectrum disorder differential diagnosis. There's Rett syndrome, Asperger syndrome, childhood disintegrative disorder, intellectual disability, hearing impairment, developmental language and speech disorders, tic disorders, stereotypic movement disorders, schizophrenia, cluster A personality disorders. Clinical management of autism spectrum disorder, pharmacological management. There's no specific pharmacological interventions. Antipsychotics can be effective for symptoms such as tantrums and aggressive behavior, self-injurious behavior, hyperactivity, and repetitive stereotyped movements. Antidepressants, clonidine stimulants to diminish self-injurious behavior and hyperactive and obsessive behaviors. Among these, for some reason, naltrexone is mentioned. I'll have to look into that. I've never heard of that. Non-pharmacological management of autism spectrum disorder. Behavioral therapy to improve cognitive function and reduce inappropriate behavior. Occupational therapy to improve sensory integration and motor skills. Speech therapy to improve sensory integration of motor skills. Pivotal response training, and appropriate school placement with a highly structured approach. Rett syndrome. Description. Rett syndrome is the development of specific deficits following a period of normal functioning after birth. Etiology of Rett disorder. The etiology is unknown. There is a known progressive and deteriorating course after an initial period without apparent disability. It is compatible with probable metabolic disorder, and is it possible to have genetic mutation that is suspected. Incidence and demographics. The disorder occurs primarily in girls. It is usually associated with an intellectual disability. I forgot to mention on the previous slide, risk factors for developing Rett syndrome. Risk factors are seizure disorder. So for prevention and screening, at-risk family education, the same thing that has been mentioned with all it. So stigma reduction, symptom of the illness, and early recognition. Assessment. Detailed history of assessment, social history, medication, and validate all the physical findings with a family member. History. Assess the following. Normal prenatal and perinatal development. Normal psychomotor development through the first 5 months after birth. Normal head circumference at birth. Onset of all the following after the period of normal development. Deceleration of head growth between the ages of 5 to 48 months. Loss of previously acquired purposeful hand skills between the ages of 5 to 30 months. And with subsequent development of stereotyped hand movements. Early loss of social engagement. Appearance of poorly coordinated gait or trunk movements. Severely impaired expressive and receptive language development with severe psychomotor retardation. Rett physical exam findings. Associated features are seizures, irregular respirations, scoliosis, loss of purposeful hand skills, and stereotypic hand movements. Rett syndrome mental status evaluation. The appearance is stereotypic hand movements. Speech is expressive and receptive language impairment. Affect is flat or blunted affect. Diagnostic and laboratory findings. No specific lab findings. CBC can profile B12 to rule out metabolic causes. Drug toxicity screening only if indicated by history, EEG, and non-specific abnormalities on brain imaging. Differential diagnosis for Rett are intellectual disability and autism spectrum disorder. Clinical management for Rett rule out or treat any conditions that may contribute to the current symptom manifestation. Pharmacological management is nonspecific. Non-pharmacological management is multimodality treatment aimed at symptomatic intervention. Eating disorders. Description. Eating disorders are characterized by disordered patterns of eating accompanied by distress, disparagement, preoccupation, and distorted perception of one's shape. Common forms of eating disorders are anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia nervosa is where clients refuse to maintain a normal body weight. It involves restricting caloric intake. Clients have an intense fear of gaining weight because of distorted body image. In bulimia nervosa, the clients engage in binge eating combined with inappropriate ways of stopping the weight gain, associated with efforts made to lose weight, usually normal or slightly overweight. Binge eating disorder is recurrent episodes of binge eating with lack of control, and binge eating occurs 2 days weekly for 6 months. So 2 days a week for 6 months, not regularly associated with compensatory behaviors. Etiology of eating disorders is multifactorial, with biological, social, and psychological factors that are implicated in the causation. Neurobiological factors include decreased hypothalamic norepinephrine activation, dysfunction of the lateral hypothalamus, and decreased serotonin. Incidence and demographics. Eating disorders are more common in girls, with 85 to 95% of occurrences. Anorexia nervosa affects approximately 0.28% of the general population. Bulimia nervosa affects approximately 1%, and the onset is typically between the ages of 14 years old to 18 years old. Risk factors for eating disorders are genetic loading, increased risk of eating disorders among first-degree biological relatives of people with certain other psychiatric disorders. Also at risk are eating disorders, mood disorders, and substance abuse disorders. Prevention and screening. At-risk family education, community, stigma reduction, and early recognition. Assessment for eating disorders are detailed history, social history, medication, initial and periodic functioning history, and validate the history with a family member. Anorexia nervosa assessment. So there's refusal to maintain a minimally normal body weight. Weight is less than 85% of the expected weight. Fear of gaining weight or becoming fat. Distorted body image. And then there's restricting type, which is the person has not regularly engaged in binge eating behavior during the current episode, or binge eating purging type, where it is during the current episode the person has engaged in binge eating and purging. Bulimia nervosa. There's recurrent episodes of binge eating. Both binge eating and inappropriate compensatory behaviors occur at least twice weekly for 3 months. Recurrent inappropriate compensatory behaviors to prevent weight gain, such as self-induced vomiting. This is with bulimia nervosa. Self-induced vomiting, laxatives and enemas, diuretics, stimulants, abuse of diet pills, fasting, and excessive exercise. With bulimia nervosa still, self-evaluation unduly influenced by body shape and weight. There are 2 types of bulimia nervosa, the purging type and non-purging type. Physical exam findings for anorexia nervosa. There's low body mass index, amenorrhea, emaciation, bradycardia, hypotension, electrocardiogram ECG changes, such as inversion of T waves, ST segment depression, and prolonged QT. So physical findings still with anorexia nervosa, there's hypothermia, yellowing of the skin secondary to carotenemia, dry skin, brittle hair and nails, lunago growth on face, extremities, and trunk, peripheral edema, hypertrophy of the salivary glands, erosion on dental enamel, Russell sign, which is scarring on the calluses of the dorsum of the hand secondary to self-induced vomiting. With bulimia nervosa, the weight is usually within normal range, erosion of dental enamel, also Russell signs, and hypertrophy of salivary glands and rectal prolapse. Mental STEM exam findings. Appearance is emaciated appearance with anorexia nervosa. The affect is there's lability, anxiety, and constricted or sad. The mood is dysphoric. The thought content is preoccupation with food and body weight, suicidal ideation, and low self-esteem. Concentration is decreased in concentration. Judgment is impaired for self-aware, and insight is impaired. Diagnostic and laboratory findings. CBC, chem profile, thyroid function test B12 to rule out metabolic causes. Drug toxicity screening if indicated by history. For anorexia nervosa, there's no definitive laboratory test for diagnosis, but laboratory changes are normochromic normocytic anemia, leukopenia, neutropenia, anemia, thrombocytopenia, hypokalemia, hypomagnesemia, hypoglycemia, and decreased LH and FSH. With bulimia nervosa, there's also no definitive laboratory test for diagnosis, but the laboratory changes in bulimia are hypotension, bradycardia, hypokalemia, hyponatremia, hypochloremia, hypermagnesemia, metabolic acidosis, and elevated serum amylase. Differential diagnoses are general medical condition, mood disorders, cluster B personality disorders, obsessive-compulsive disorder, and schizophrenia. Clinical management of eating disorders. Rule out or treat any conditions that may contribute to the current symptom manifestation. Pharmacologic management, medication management as adjunctive therapy to psychotherapy. So psychotherapy is primary. No specific medication therapy for anorexia nervosa. Fluoxetine is FDA approved for bulimia nervosa. SSRIs and tricyclic antidepressants are effective in reducing the frequency of binging and purging. So fluoxetine is FDA approved for bulimia nervosa, and SSRIs and TCAs are effective in reducing the frequency of binging and purging. Treat associated symptoms such as depression and anxiety with the appropriate pharmacological therapy. Non-pharmacological management is multimodal treatment, medical and nutritional stabilization, weight restoration, correction of electrolyte disturbances, vitamin supplementation, and nutritional counseling. Dental care. And then there's psychotherapeutic interventions, individual therapy, behavioral, cognitive, family, and group, and community resources such as eating disorder support groups and 12-step programs. For follow-up and eating disorders, regular follow-up with a multidisciplinary team is necessary. Intellectual disability. Description. Intellectual disability has an onset during the developmental period and includes low intellect and adaptive functioning. The onset must occur before the age of 18. There's mild, moderate, severe, or profound, based on adaptive functioning and not just IQ scores. Actually, it says just not IQ scores. So intellectual disability is based on adaptive functioning, not IQ scores. IQ scores are less valid on the lower end of the IQ range. Etiology of intellectual disabilities. The heredity accounts for 5% of cases. Inborn errors of metabolism, such as Tay-Sachs disease. Single gene abnormalities, such as tuberous sclerosis. And chromosomal aberrations, such as translocation of chromosome 21, that's Down syndrome, and X-linked gene of FMR1, which is Fragile X syndrome. Early alterations of embryonic development account for 30% of the cases. Prenatal exposure to toxins such as maternal alcohol consumption or infections. Pregnancy and perinatal problems account for 10% of the cases. Fetal malnutrition, premature birth, fetal hypoxia, and birth trauma. There's no clear etiology that can be found in 30 to 50% of the cases of intellectual disability. The most preventable cause of intellectual disability, so the most preventable cause of intellectual disability is fetal alcohol syndrome. Characteristics of fetal alcohol syndrome include epicanthal skin folds, low nasal bridge, short nose, indistinct philtrum, small head circumference, and small eye openings. And I forgot two others, wide set eyes and thin upper lip. The prevalence is 1% of the general population. Demographics is highest rates are reported in school-age children 10 to 14 years of age. 1.5% more males than females. And risk factors are genetic loading and adverse birth defects. Prevention and screening are at-well baby examination and school screenings. The physical exam findings are oblique eye folds, small flattened skull, large tongue, broad hands with stumpy fingers, single transverse palm crease, high cheekbones, small height, brush field spots on iris, abnormal finger and toe prints, cytotritism or cryptorchidism, congenital cardiac defects, early dementia, and hypothyroidism. Mental status exam findings for intellectual disabilities are communication deficits, dependency, passivity, poor self-esteem, low frustration tolerance, aggressiveness, stereotyped repetitive motor movement, and self-injurious behavior. There are no specific diagnostic and laboratory findings. Some laboratory findings associated with a variety of causes of intellectual disability could be metabolic disturbances. Differential diagnosis for intellectual disability is borderline intellectual functioning, learning and communication disorders, pervasive developmental disorder. 75% of people with pervasive developmental disorder have comorbid intellectual disability. Other differential diagnoses are ADHD, stereotypic movement disorder, and a general medical condition. Clinical management of intellectual disabilities are the pharmacological management. The treatment is symptom-specific. Treat concomitant psychopathology such as with ADHD, depressive disorder, anxiety disorder, or schizophrenia. Aggressive or self-injurious behavior may be controlled with antipsychotics and mood stabilizers. Non-pharmacological management of intellectual disability disorders are therapy, behavior group, family, community resources, daycare settings, shelters, workshop, and group homes. Okay. Moving on to disruptive mood dysregulation disorder. The description is childhood depressive disorder that is diagnosed in children older than 6 years old but younger than 18. The features of this disorder are chronic dysregulation of mood, frequent temper outbursts, and severe irritability. And I'll repeat that the diagnosis is made in children that are older than 6 years old but younger than 18. Disruptive mood dysregulation disorder, etiology, causes unknown. Prevalence is it affects about 2 to 5% of children and adolescents. Higher incidence in boys, school-age children than in girls. That's for disruptive mood dysregulation. The risk factors are complicated psychiatric history, including comorbid ADD or ADHD. Prevention and screening for disruptive mood dysregulation disorder are children and adolescents should be screened for a personal and family history of bipolar disorder, as symptoms of disruptive mood dysregulation disorder can be similar to bipolar disorder. So assess for bipolar disorder, for oppositional defiant disorder, ADHD, depressive and anxiety disorders, autism spectrum disorder. Clinical management, pharmacological management is medications can be used to treat the target symptoms of the disorder. SSRIs, mood stabilizers, atypical antipsychotics can be helpful. Non-pharmacological management is individual, group, and family therapy are helpful. And I am almost to the end of this book. I am so excited. All that's left after this is sleep, violence, and practice questions. So that's it.